Hello, this is Dr. Bhawmik and welcome to my YouTube presentation and the lecture series. This time we are going to do a little bit different in the sense that I'm going to present lots of interesting cases that is known to the pediatric endocrinologist or pediatrician but is rare, indeed rare in pediatrics. So therefore the presentation is going to be in the form of case presentation, pertinent clinical findings, evaluation, investigation, and then I'm going to discuss the up-to-date knowledge that we have about that condition. And the case that I am going to present, and in future the case that I will be presenting, these are our own cases, and we have been very fortunate to see many of very rare cases. And many of these unique cases has been published in peer-reviewed journal, Clinical Pediatrics or Endocrine, and also has presented in regional pediatric endocrine society meeting. The link I will put in the description section of this video in details. The case that we are going to discuss today is excessive growth in a toddler. And in this case, my colleague was Dr. Anne-Marie Koffers, and we have investigated the case together, and this was very interesting to both of us. So in introduction, I like to say that tall stature is less of a concern in pediatrics, especially so in boys. And in girls, in the tall stature is there, and I would request you to listen to my lecture on evaluation of tall stature in pediatrics for details of tall stature patient and how to evaluate them and the differential diagnosis. Okay. And therefore, the referral for tall stature is less common, and especially if they happens to be a boy. However, it is very important for the pediatrician to recognize and identify the abnormal and accelerated growth pattern. So we are going to present a case of child with excessive growth, and we'll discuss the key point of hidden history and physical examination, and discuss the pertinent lab and imaging studies, differential diagnosis, and also the treatment option and up-to-date information that we can gather from the present state of our knowledge. So this was actually a 2 years, 8 months old Caucasian female and referred to us for excessive growth. The increased growth, according to the mother, was started at early age, but mother reports that has grown 4 inches in 4 months. She is clumsy, incoordinated, and looks like she may have some vision problem, according to mother. However, deny the history of headache, vomiting, or abdominal pain. She was born at 38 weeks of gestation. Her birth weight was 7 pounds and 1 ounce, and birth length was 21 inches. She had tonsil and adenoidectomy done at the age of 2 years for sleep apnea. She has also eczema, which required intermittent therapy with a steroid cream. Developmental history, she actually walked around 1 year of age, She does speak full sentence, however difficult to understand. And she also have problem with coordination and tend to fall a lot, according to mom. The family history: the mother's height is 5'7", dad is 5'11", in the active duty military service, and both of them are actually in a very good health. No family history of tall stature, no family history of any endocrine problem like adrenal, thyroid, or pituitary disorder. Physical examination: she has normal vital signs. Her weight is above 97 percentile, which will be shown on the growth chart, and her height was 113.8 centimeter, and which is above 97 percentile, and height is of 6 years. She does have some dysmorphic feature: arched eyebrow, elongated face, prominent forehead, large hand and feet. Her her genital examination is prepubertal. Physical examination also shows she has bilateral hemianopsia. Extraocular movements, however, intact. No nystagmus or papilledema. Skin is moist, smooth. No cafe spot or no neurofibromatous lesion was appreciated. And this is the initial growth chart, which shows that there is some increase in growth velocity from the age 2 onwards. Earlier it says 6 months onwards. However, next one will also tell you that this is when we saw, and you can see right there, and it is definitely above 97 percentile, and increased growth velocity is clearly identified. So at this point, our differential diagnosis was cerebral gigantism, and I have discussed cerebral gigantism in details in tall stature lecture. And these children are born big, and their growth rate continue to be high or more increased growth rate up to the age of 4-5 years, and after that it slows down. Final height, they are tall but not abnormally tall, and they do have some problem with coordinations and other that has been described, and I am not going to discuss more about this condition. Familial tall stature is this. There is a family history of tall stature, and obesity, and that's again discussed in the previous lecture, is that about 70 to 80% of the children prepubertally with obesity will have growth curve above 97 percentile. So this is non-organic obesity, precocious puberty, and congenital adrenal hyperplasia, and they both have increased growth velocity, and they tend to grow faster. Their bone is advanced significantly, and as a result of their final height, they are short, but initially they are tall. But appropriate test will identify, and appropriate treatment will slow the increase in growth velocity. And then we left with a growth hormone excess, which is indeed very rare, and that's what we are going to discuss today. So some of the lab findings that we did is showed that her CBC is within normal range, basic metabolic profile normal, her FSH, LH, estradiol, 17 OSP, dihydroepiandrosterone sulfate, they are all normal for the age. Her free T4 at DSH and serum cortisol was also normal. Growth hormone, prolactin, IGF-1 and IGF-BP3 is in the table. In the initial visit, she has a random growth hormone of 158 and prolactin of 511. IGF-1 is 558 ng per ml, and IGF-BP3 even 7,300 ng per ml. As you can see, they are significantly elevated. And we repeat that one in about 48 hours. And the repeat one shows also random growth hormone is 185, and growth hormone prolactin is again elevated to 601. IGF-1 and IGF-BP3 is again significantly elevated. Now, this patient was treated with Doshinex, waiting for the final evaluation and the treatment proposal. And actually, 3 weeks after the Doshinex treatment, there was a reduction of the growth hormone and prolactin. But after 4 weeks, it started to going up again, and that we will discuss a little bit more in the later part. So Ray Bonis was 4 years and 9 months by Gulick and Pyle method at a chronological age of 2 years and 8 months. And head CT revealed a soft tissue mass 1.4 centimeter by 1.4 arising from sella tunica, and contrasting MRI of the brain is next, this diagram. So as you can see very easily that the big right here is our adenoma or the lesion, and it was 1.9 by 0.85, and it was read as pituitary macroadenoma. As I said, that as we are discussing with the neurosurgeon, neurologist, and what approach should be taken and when do we send this patient for surgery, since we did not have such a strong neurosurgical team. So as I have indicated before in the chart that 3 weeks after carbapenem treatment, and it did come back a decline by more than 50%, but it started going up from 4 weeks onward. Okay, now this patient was then referred to NIH, and where the further study was done, including the gene studies, and the tumor was removed by transsphenoidal resection. And the pathological finding was growth hormone and prolactin secreting macroadenoma, and there is a hyperplasia of both growth hormone and prolactin secreting cells. And they also did the study for AIP, or which is called hydrocarbon receptor interacting gene mutation, was not found, which actually present 50% of all genetic mutation that has been seen in pituitary macroadenoma. Actually, this gene is located on chromosome number 11 and 11q-13 band. And this is a familial, and this gene, presence of this gene also called is a familial pituitary macro, found in 50% of the cases in familial pituitary macroadenoma. So that was negative, and so therefore the follow-up of growth hormone after 6 weeks after treatment was very low, and patient did develop hypopituitarism and central diabetes insipidus, and that was expected, and was started with the DDABP, hydrocortisone, and thyroxine supplement appropriately. And this patient was not on growth hormone. However, followed in endocrine clinic and another institution by talking to the pediatric endocrinologist over there, and this patient was started on growth hormone 1 year after surgery, since her growth velocity declined significantly, and she required growth hormone for further growth. So, as you know, that this is what we call open epiphysis gigantism, and this is called pituitary gigantism. And when the epiphysis is closed, and that's what we call acromegaly. And the gigantism is very rare in children, and they only reported in sporadic cases in the literature. And the best estimate is around 100 cases are reported in children. However, it is extremely rare, less than 3 years of age, and that's another unique point. I do believe that there is probably more cases which has not been published or reported than 100 cases per children, but that's what I could find. And clinical features of gigantism not only increase growth velocity, but they do present with some of the features of acromegaly. And that's like your frontal bossing, large hand, feet, visual disturbance, macrocephaly, and present in most cases. And the coarse features was also noted in our patient. Mild degree of obesity and macrocephaly is also seen in our patient. So pathophysiology gigantism is often caused in children by pituitary adenoma, and most of the time those macroadenoma is benign, but it could be malignant, and it is likely to be locally invasive or aggressive in some cases. Hyperprolactinemia may be present in about 50% of the cases, and as was in our case also. In our patient, the adenoma comprised of both somatotrophs and or somatotrophs or prolactin secreting tumor. Growth hormone prolactin has been found within the secretory granules in the cytoplasm of the tumor cells. So, just to mention some of the points that need to be recognized, that pituitary adenoma is not only can produce excess growth hormone, but it could be with McCune-Albright syndrome, neurofibromatosis type 1, multiple endocrine neoplasia, and type 1. This mostly is acromegalic features in adult, but it could be in children, but tuberous sclerosis or Carney complex. And these are the things associated with, and they are not necessarily that all of those cases, not all of the neurofibromatosis or McCune-Albright syndrome will have excess growth hormone, but those are the possibilities, and they should be recognized and should be remembered in the differential diagnosis. And this itself is a different discussion, and I am not going to discuss that here. So presented with a situation like that, when you feel that everything else is negative and history-wise and other thing, and you are suspecting that it could be growth hormone secreting situation or pituitary adenoma or hyperplasia, I think very sensitive test is IGF-1. And we also do IGF-BP3 at random, and this was definitely way, way high. Now, in our cases, we did not have to do the glucose GTT, and which may be necessary in some cases, especially in the adult, because our baseline growth hormone was so high. As far as the imaging studies are concerned, is just a contrast CT and MRI is the way to go. And it is very important to recognize that these patients should be managed, especially that a surgery is contemplated in the best possible center where there is a very good pediatric neurosurgery capabilities are available. So treatment is the best treatment is, if it's possible, is a transperiodal surgery, and the removal of the tumor as completely as possible is the goal. And again, as I said, the surgical cure depends upon the surgeon's experience, size, and the extension of the tumor mass. And it should be made clear to the family that after this surgery, they are going to need the hormonal supplement. And this was a little problem with our patient. The family wanted to do the surgery but was very much against any hormone replacement therapy. But they actually went to 3 places and finally they settled in NIH. And as usual, the patient did develop multiple hormone deficiency, which was quite expected. If surgery is not possible any other way, then pituitary radiation or the medical therapy with somatostatin analogs or dopamine agonist has been successful, and growth hormone receptor antagonist used successfully in acromegaly by our adult colleague. So in conclusion, that growth hormone excess is rare and must be considered in abnormal or accelerated growth children. Pituitary gigantism exhibit some of the acromegalic features. Hyperprolactinemia is commonly seen if it is secondary to plurihormonal adenoma, multiple hormone secreting adenoma. But a lot of time it could be just growth hormone excess alone. And long-term endocrine follow-up or lifelong endocrine follow-up is necessary. So therefore, this kind of case, there are pediatric endocrinologist who has been practicing for many years but has not seen one. We are fortunate to see one, and I think the best way of knowing this case is to managing one, and we like to share this one with the endocrinologist and the endocrine fellows so that they can have a better understanding of this condition. And thank you very much. And this patient was also a patient we saw together, and with Dr. Coffers, who is now the professor of pediatrics at University of South Alabama College of Medicine.